I will start out by talking about the sequential treatment of the chronic venous insufficiency. And this is made as a framework for you to hang up the other discussions on. Now what we are talking about is the C3 to C6 class. We can have severe leg pain, extensive grade 3 swelling, discoloration, dermatitis, lipodermatosclerosis, and venous ulcers. So these are patients that have a significant disease. And I will remember you, I want to remind you of the complexity of the disease with the calf muscle pump, the reflux, the obstruction, and the microvascular pathology. And when we do surgery, or some sort of interventions, we will affect only part of this complex situation. I would also like to remind you of the fact that in the venous system you have a proximal confluence area in this, and you have one in the popliteal region. So one in the femoral and one in the two makes two different levels. And then you have parallel systems that we have discussed before with the axial deep system, we have a profunda system, and we have a superficial system, and some interconnections with the perforators. And when we describe the disease, we can talk about single level, single system, we can talk about single level and multiple system, and then we can have several levels. Now we have already discussed the diagnostic accuracy, and we know that we cannot quantify reflux, but we can only qualitatively describe it. And the obstructions were even worse because we don't know at what degree of venous obstruction is hemodynamically significant. So we end up with these two statements here, that is unable to assess the contribution by the individual segments in regards to reflux and or obstruction to the global hemodynamics, and therefore we cannot target our treatment when you have multiple problems. So what is important in these patients? Is this an obstruction, or is it a lack of valve function that is important? And which is the dominant pathology here? And you can have similar thing with primary disease. So when we approach the chronic venous insufficiency, as we have pointed out before, it is important to initially investigate the patients. We have gone through the sequential, of course the mainstay is the duplex Doppler, but you have to include the pelvic outflow, and you might have to add other investigations to complete it. And for your line of thoughts, it is important that you classify the disease not only in its severity, but also etiology, anatomy, and pathophysiology. And then you start with conservative treatments when you consider as you consider the invasive procedures. And I hope that you're all familiar with the SIP. The different clinical classifications are usually the ones that you use, but you also have to think about, is this a primary disease, post-thrombotic disease, congenital disease? You need to think about it, is the deep system involved or combined with the superficial perforators? And you have to think about it, is this a reflux part or is it a obstruction part? And when you do that, you can then approach the treatment. Now when it comes to the treatment, we have to make some important observations regarding the chronic venous disease. As I told you before, the therapeutic approach is blind. It's really trial and error and not directed towards the dominant pathology. We know that if we do one part, repair one part of the venous system, we can actually put the patients into a compensated system, and that means that we don't have to correct everything we find, we can do a partial correction. And then thirdly, we have to realize that we don't really cure the patients. So when we choose our treatment, since we cannot be led by the investigations, we choose them because they are simple, they are minimally invasive, they have low mortality and morbidity, and of course they should have a favorable income in the patient. So this is a sequential treatment that is emerging as the new paradigm, and that is in the combination of several systems and reflux and obstruction, the venous stenting of the iliocaval venous outflow obstruction should be a primary intervention. Superficial system, and down here comes the deep valve repairment. Of course, we have to continue the compression therapy and local ulcer treatment as we consider the interventions. Femoral stenting comes into this simple, low mobility, well-documented clinical outcome procedure. And we know about the post-thrombotic obstructions, which are quite obvious to us, but we also have to remember that you can have non-thrombotic iliac vein lesions, which appears to have a greater impact than we really thought before. Remember that it's not only compression, but in 30 to 40% of the cases, there is intraluminal changes with webs, spurs, and cords. And also remember that these patients are not only young women with problems with the left lower extremity. They can be on the right side, they can be male, they can be older, and they can have not only a proximal classical lesion, but they can have lesions in these other positions too. So they can have a clinical impact without the previous DVT. And these are X-rays showing the left side and the right side, combinations of the lesions. And this is just to show that a very elderly patient with calcification of the aorta can actually develop in the inflammatory response around here a May-Turner syndrome. And you can clearly see the outline of the artery here. What is interesting with the stenting is that regardless of presence of reflux, you have a high rate of healing. And this looks funny here, but that is because those patients that did not heal within 3 months and were lost to follow-up were considered non-healed at 3 months. So this is why it drops down here. But then you see it's very flat. So it seems as though when you heal an ulcer after a relatively simple procedure of stenting of the outflow, it stays healed. And it's very few recurrences during this time. Just finally wants to show you a combination of diseases. If you have an iliocaval outflow obstruction and superficial incompetence, this is a group of patients that have that. And these are with reflux here, and you can see that the patients have superficial reflux, 32%, deep only 20 combinations. And if you treated this group of patients that had reflux, and then compare those to those that had only outflow obstruction and saw the results, you can see that they are similar in both groups, although this reflux was never treated during this observation period. And that's to show the impact of non-thrombotic iliac vein outflow obstruction. And here we have a similar situation where we have deep reflux. And this is 528 patients that had C4 to C6 in 52% patients, the rest were C3 and pain. And you can see that all had a deep reflux. This was 33% only, plus superficial of 65, perforated 24, axial reflux here, and the number of segments involved. And we went in and did stenting of this patient alone, not treating any reflux. The result after 5 years was similar, that the ulcer healed at 54% and stayed healed over 5 years period. Recurrent of C5, this is what patients that have had an ulcer and at the time of surgery were healed, and they recurred in 12%, and those patients with severe dermatitis, they healed in 81% cumulatively over a 5-year period. The final last procedure is when you combine stenting with superficial ablation. And this is a group of patients that all have superficial reflux, 242 of them. And you can see they are subgrouped into a group of patients that did not have any deep reflux, those that have segmental reflux only, meaning that they didn't have an axial reflux going from the groin all the way down into the calf. And then finally a group that had axial reflux. And of course, when you look at the C3, C4, and C5 to 6, you will find more axial reflux among those patients that had higher classifications here, which is normal. When you go in and look at after 3 years, after stenting, and combining that with saphenous ablation, you find that you had an overall cumulative rate of ulcer healing of 78%. When you go down and look at those patients groups with no deep swelling or segmental swelling, you had a very high rate of ulcer-free period. On the other hand, those that had an axial reflux had a lower cumulative healing rate. And then that is the group that are candidates for valve repair. And as you can see, and we will hear later on, these are the indications. You have to clean up the system, they have to have severe problems, and they have had to have recalcitrant ulcers that have treated appropriately with conservative therapy. And we treat patients with axial reflux, those we are considering valve repairing. So the evolving principles of invasive treatment is that we, of course, try the minimally invasive procedures before open surgery. The iliofemoral obstruction should be treated before axial reflux in combined disease, and the superficial reflux before the axial deep reflux. And you can combine stenting with ablation, even in the presence of axial deep reflux, and later on the list comes the deep valve repair. As you know, we don't have any percutaneous artificial valve, and if we find those and they are efficient, it might change this paradigm too, of course. Thank you very much.